Thanks for joining us in this side meeting of the Prisma Hidol Award Conference. And in this session, we will be reviewing what has been an impressive observation in terms of the divergent path the epidemic took in Asia, where it originated, and in the West, here defined as the European Union and North America. To do so, we are going to be presenting the results of an ecologic analysis contrasting those countries in the regions, after which we will hear from Simone Villa from Milan University on the methods and the thick of the results of the ecologic analysis, followed by Hilary Brown, who will be talking about some of the social considerations, many of which seem to be very relevant to this pandemic. I will then have a few extra comments on what we thought was going to be a big wave and which might still happen in Asia. And finally, open up for comments and your questions. You do have a question and answer section in your Zoom that you can use to write in your questions, and we will be following those to try to address them directly by the speakers when the time comes towards the end of the session. I also am told that the session is being recorded so that it will be available for others who want to watch it later on. And finally, the secretary asked us to remember that you will have an evaluation mini questionnaire that you can also please submit. And with that, I would like to simply start saying this will be the program, as you know, and may I get the next slide, please? We all know that the epidemic began in Wuhan and in green, actually, very early on. And then next click, then Thailand saw this epidemic outside the Chinese borders for the first time. And despite which, as you can see, it was really in the rest of the world where the pandemic took off. This was observed very early. Next slide. And one of the first observations and important lessons for all of us from the very beginning was the clear difference between this pandemic and H1N1, where in this case, it was the elderly who were being really the most vulnerable to the mortality by COVID. And this lesson has been very important in guiding policy, although the policy has not always been shaped around this very, very important differential between the risk almost 1,000-fold in the elderly compared to minors. And Asia also was giving us some early lessons. Korea, with a very early success, given their well-timed response without lockdowns, basically intense testing, contact tracing, and quarantine, and they seemingly contained it early on. It was an awesome thing to see as we were seeing Milan succumb to the pandemic. Likewise, Japan, even though they had a very elderly population, which, as I said before, was a very important risk factor, they were very successful early and also without lockdowns by avoiding the 3 Cs, as they call it in Japan, avoiding close environments, crowds, and close contacts. And even though the policy did not emphasize masks, it seems that that was a bit more natural, as we will see later in the region. The next slide, please. And when we started this, the China Medical Board, who was interested, of course, in what's going on in the United States and in Asia, we were observing, of course, the obvious discrepancy between the exponential explosion in Europe and the United States, whereas in Asia, they were indeed quite successful in flattening the curve, as we discussed back then. And this difference, which to the naked eye suggested almost like a 10-fold mortality. And I have to say that we have focused on mortality rates as the key indicators, given the number of cases depends so much on testing, particularly with an epidemic where there are so many cases that are go unreported, in almost half of them asymptomatic. So this almost 10-fold mortality rate in the West versus the East inspired us to look at what will be the factors and also predict whether by the end of the 2020 year, we had a concern that Asia will be more vulnerable and see a second wave like the one we had experienced in the West. That was what we expected. Some of us expected it. It was a concern for all of us. And so that was what initiated, with support of the China Medical Board, this exploration. Next slide, please. Next. So with that in mind, we had three questions. First, what were the factors, the baseline factors, and what type of response to the epidemic contribute to this early success in the East versus the West? And I have to say that originally we were focusing on Southeast Asia, trying to drill into a smaller number of countries, but for the number of countries with more than 1 million people, there is only 9, so we expanded to the rest of WIPRO. So the East was constructed, as we hear, second compared to the West. And our second question at the time in August, a burning question, was whether lacking herd immunity in the East will make them more vulnerable to a big wave by the end of the year, to a COVID resurgence. And of course, we now know the answers to that, and it's been quite dramatically in the opposite of what I expected, and thankfully in a way for Asia, but quite bad for the West. And we will explain a little bit of what that could mean. And third, whether we could derive any implications or lessons for our current epidemic. I think as things are still are quite fluid, even with the arrival of the vaccine. Next slide. I will pass it on to Simone Villa.
Hello everyone, I'm Simone Villa from the University of Milan. I will show the current ecological study we have performed. And as Professor Ariel Pablos Mendez said, we focus on different settings. So the West, that was defined including all the countries in European Union and United States of America and Canada. And the East, that we included all the countries of Southeast Asia, and as Professor Pablos Mendez said, also the over WHO WIPRO countries, so Australia, China, and the one listed in this slide. The aim of this type of study was to investigate what factor may be responsible for the different consequences caused by the current COVID-19 pandemic. And we focused on 4 types of variables. So the baseline characteristic of the population, of the health system, of the economy of the country listed in the previous slide, the epidemiological COVID-19 data, so data reported from reported cases of COVID-19, reported deaths, and test case fatality ratio, and so on. Interventions implemented by governments, so the one aimed to flattening the COVID-19 curve locally, and the impact of the COVID-19 pandemic in different fields, so the economic one, but also the social one that Professor Hilary Brown will talk about later. So the main source of data were different for different type of variables we have included in our databases and analysis. The analysis was performed using mostly every country in the world with at least 1 million population in the scatter plot I will show you later. And we use a linear regression model, and sometimes we have to perform a log transformation to linearize the fit. So, sorry, the results of the ecological study were, as Professor Pablos Mendez said, were mainly focused on the mortality due to COVID-19 based on the reported death due to COVID-19. So in this slide, we compare the mortality in the West, so the yellow one, and against the East. So we have like a 100-fold difference between these two types of regions if we look to the median mortality value. So some countries in the West have similar mortality rate of the East, like Norway, Finland, and Iceland. But also in the East, we have some countries like South Korea and Singapore that has a slightly higher rate of mortality compared to the rest, but it's always around 0. So we can say 0.5, 0.6, sorry. So in this slide, we display the different trends in daily cases of COVID-19 and daily death of COVID-19. So in red, we can see the COVID-19 deaths, and in blue, we can see the daily COVID-19 cases worldwide, in the West and the East. So we can see that this is the same unit of measure. So we have that the East, in the East, the COVID-19 pandemic had impacted the less compared to the West. This is during the whole 2020 year. The case fatality ratio through the past year has changed during by month, and we see here the different case fatality ratio trend for Asia, for United States, and European Union. So while countries improved to manage COVID-19, to impose measure to bend the curve and improve the therapeutic strategies against COVID-19, the trend of case fatality ratio changed. And if we go to see United States, for which we had the individual level data, we looked for the median age of cases in blue and for deaths in red. We can see that also the mean age for cases changed during the past year, but yes, for deaths, the mean age of those who died is quite the same throughout the 2020. And just to remember that this is only the cases and deaths that are reported. Some of the cases and some of the deaths are missing. So we are just looking at the top of the iceberg, so to say. If we go to look at the testing trends, we can see that there are changes over why these testing trends are by quarter. So we divided the past year in 4 quarters, and we can see that cases, the positive rate in the first quarter was pretty high in the West compared to the East, especially against the rate observed in the world. And also in the quarter number 4, so the last quarter of the past year, the positive rate of the test was pretty high, 7.8, compared to the East. And the same we can observe also for the COVID-19 tests performed per confirmed cases that change over time and are particularly high when the positive rate is low. While if we go to see how COVID-19 cases, death, and case fatality ratio, median reproductive rate, the incidence and mortality change throughout the year, divided by quarter, we can see that the West was more impacted compared to the East, especially if we go to see case fatality ratio, as well as incidence, which topped to 3,000 against the 5.2 in the last quarter of the year. For the incidence rate, we here are displayed the median value in the region, so the West and the East, and range, so the minimum value and maximum value. So the figure is pretty much worse in the West compared to the East, and also compared to the median value for the world as a whole. And yes, pretty much also the mortality in the last quarter was very high compared also to the one in early in 2020. If we look to the whole year, the situation is quite similar again. We have that mortality was much higher, 100-fold higher in the West compared to the East, and as well the incidence, and while in the median reproductive number and case fatality ratio, the situation was a bit worse in the West, but were pretty much similar to the East. While if we split, sort of say, the world in countries that has a median age below the global median value, the mortality rate is very low, 2.5, against 40.3 when for countries that has a median age above the global median value. So perhaps age could be a factor that can display this different scenario we see from the West compared to the East. If we go to see the mortality by quarter in these maps, we can see that the West was impacted the most throughout the different quarter of the year. And also if we go to see, for example, Sweden, we can see that the mortality there was pretty higher compared to the country nearby. And if we go to see the numbers, we can see that mortality, as we see the previous slide in the table, was always higher in the West compared to the East, that was always around 0, 0.2, 0.3, etc. So we have gone through the risk factors for to see what type of risk factor could impact the most. So we started with the demographic ones, and in this table are summarized some of the risk factors. And we also compute the Pearson correlation test against the mortality rate for COVID-19 throughout the whole year 2020 with a log transformation. So we see that some of the factors listed here and highlighted in red has a higher correlation, so median age, but also the countries that has a population, a share of population higher for those aged above 65 years of age. Also the urban population, so the share of the population living in urban settings, and as well as the prevalence of obesity. This type of prevalence is listed here, are all of them age adjusted from the WHO. If we go to see the differences from the West compared to the East, we see that those age above 65 years of age are much more represented in the West compared to the East. We have 20% of the median value from the West. 20% of the people in the West are age above 65 years of age, while only 6% are those in the East. And a similar picture we can also see for the urban population. So the share of population living in urban places, 77 in the West compared to 57%. And as well, a different picture we can see for the population living in large households, where large households are defined as households above 4 members, so that are much more represented in the East compared to the West. Obesity as well is similar in the West and in the East, a slightly higher in the former one, and a different trend we can see for the raised fasting blood glucose in adults. So that is a bit higher in the West compared to the East. And the current tobacco smoking is quite similar, but a bit higher in the West, and the correlation is quite good. So we pass to investigate age. So in this graph are represented all the countries above 1 million population. In red, we can see Eastern countries, while in blue are represented the Western one. The proportion of elderly is log transformed to linearize the fit, as well as the COVID-19 mortality during the whole year. And some countries are excluded. So we can see that there is a sort of association, we can say. Also, always keeping in mind that these are ecologic studies, so it has its own limitations. And the correlation factor is pretty higher. Obesity prevalence, age adjusted, always, is also correlated for associated to a higher COVID-19 mortality. And we can see that the Western countries are also represented in blue, and some of them have a higher prevalence of obesity. And while in red, we can see a quite different trend for the Eastern countries. But a correlation seems to exist between COVID-19 mortality and the prevalence of obesity among adults. But in this slide, it seems that the same situation doesn't exist for diabetes, so the raised blood glucose. So it includes people with raised blood glucose, but as well those in medications from the WHO databases. And an association doesn't seem to exist. We can see that Eastern countries, as we saw in the previous table, have a higher proportion of the population with raised blood glucose. Urban population seems to play a role on COVID-19 incidence. Here is not more COVID-19 mortality in this slide. And the same trend seems to exist if we see the Eastern countries, while Eastern countries are with different share of the population living in urban settings, seems to have quite a similar COVID-19 incidence in this slide. But a correlation seems to exist. While if we move to the next slide, we see that the situation is reversed. If we go to look the large households, so the share of the population that lives in households with 4 or plus members, also against the COVID-19 incidence in these pictures. And we can see that these act mostly for the Eastern countries compared to the Eastern one that are, the Western one that are concentrated here. But perhaps we can discuss it later in the discussion. What can be an explanation for this factor? And we also included the air transport passenger carriage, so the air passengers carried during 2029 against the COVID-19 incidence, so from COVID-19 cases reported up to June 30, so the first quarter, the first semester of the year. And we can see that there is an association that may somehow explain why some countries were hit the most, but it's not the strongest one, as we can see in this slide. We then moved to look for the system capacity and COVID-19 impact. And in this first slide, in this table, we have listed the healthcare capacity, so the medical doctor density, hospital bed density, and the universal health coverage service coverage index, and some economic and health expenditure factors. So if we go to look at the comparison to the West against the East, some of them are higher for the West. So we can see that medical doctor density are higher in the West, hospital bed density as well, and as well as the universal health coverage services. But the situation of the impact of COVID-19 in the West was reversed, as we also have shown in the previous slide. If we go to see the economic and health expenditure, we see that the GDP per capita is higher in the West compared to the East, and also the current health expenditure per capita, or as a percentage of the GDP, is quite higher in the West compared to the East. But if we move to the share of the population covered by at least one social protection benefit, this is likely to show a strong correlation and is mostly associated to the West, even though the West was less protected by that. It was most hit by COVID-19. In the first slide, we saw that the universal health coverage was higher in the West, as we can see here, and it seems to be correlated to a higher COVID-19 incidence. But again, this could be this perhaps could be explained by other factors that may act on the COVID-19 pandemics. We can discuss later. So the restrictive policies and economic consequences. In this table, again, we have listed the three different settings, the World, the West, and the East, for preparedness and response. So we have retrieved data from pandemic preparedness from the International Health Regulations Core. And that seems correlated. So it has a higher person correlation factor. And we also included in this table the one of the democracy index. That is the score from 0 to 10 and is higher in the West compared to the East, and it seems to be associated the COVID-19 mortality log, as we said. If we go to see the an index of interventions adopted, we use the one developed by the Oxford University. So we divided by quarter and the whole year. We see that in the West, the situation in the first quarter was quite low compared to the East. So the East, even though are quite low, both of them are quite low, the East seems to be seems to react more promptly. And if we go to the next quarter, we see that the stringency index raised in the second quarter, and again but again in the last quarter, but less than the second one. So the situation kindly adapted to resume the economy, and this is the situation in map. So we can see that in February 29, very few countries have a higher stringency index. So the stringency index may be like a lockdown index. It's not a lockdown index, but also include different policies act to bend the curve. So China, Italy, and few other countries has a higher index. So in February 29, there were the first cases in Italy, and then the pandemic sort of spread through Europe. And if we go to a month later, we can see that every country in the world, virtually every country in the world, has had a higher stringency index. So many countries has moved to lockdowns to bend the local COVID-19 curves. And we can see also the trends, the different trends in this stringency index, and virtually every country raised their action, started to act to bend the curve from March 2020, and especially the first one, as we already know, was China. This is this one in blue, and Italy was sort of the second, including also with South Korea, that just went to lockdown or just asked to ban the local curve. International travels as well has changed over the year. This is the situation at the start of the year, so end of January. And only few countries has had banned passengers coming from some countries with COVID-19 cases recorded. While if we move to 2 months later, virtually every country have implemented a sort of ban or sometimes only screening, while screening was the preferred policy adopted 2 months before. Also changed during the year, also the mobility changed. So this is the retail and recreation sector through the Google. So we see that the mobility in these sectors dropped in March, April, and was resumed not to a normality level to the baseline, but was resumed in the summer for the Northern Hemisphere. And we can see here the residential areas that with lockdowns, everyone was at home. So we can see here, for example, Italy, that went in lockdown in this period, while we can see Sweden as a much lower proportion of people spending much more time at home compared to the rest. And yes, I have finished my part. And Hilary, if you want to.
Thank you, Simone. And let me just acknowledge also, as Hilary comes in, that our chair, Lincoln Chen, is now also on board. Thank you, Lincoln.
Okay, hi everyone. I'm Hilary Brown with William Patterson University, and I was tasked with looking at the social aspects of the response to COVID-19. So the first slide speaks to the economic impact of COVID-19. We looked at the relationship between COVID-19 mortality and the difference in GDP between December at the end of 2019 and the end of 2020. And so we see where the economy did worse, there was greater mortality. So this speaks to the false dichotomy between health and between COVID-19 and the economy. Next slide, please. So there's been this forced prioritization of whether we prioritize health or whether policymakers are prioritizing health over the economy. But in this caricature, we see that both the economy and COVID-19 are causing deaths. And this is because the economy, and specifically income and jobs, are a social determinant of health and well-being, especially in countries where health insurance is predominantly employment-based. Next slide. This slide is looking at the relationship between the Gini index and COVID-19 mortality. This was a bit of a surprise because where the Gini index is higher, COVID mortality is actually lower. This inverse relationship shows the countries worst hit by COVID also had greater reductions in GDP, which caused greater economic inequity and will be felt for years to come after the pandemic ends. Next, we looked at inequity and COVID and found that, as assumed, COVID-19 is exacerbating within country inequities. So we looked at various socially stratifying factors from race, ethnicity, gender, income, and place of residence. So first, some examples of race ethnicity are that Black and Hispanic populations make up a disproportionate number of COVID deaths in the US. Specifically, Black people are dying of COVID-19 here in the US at 2.2 times the rate of white people. With regards to gender, the rate of people in ICUs and the rate of deaths is higher among men than women, which holds true across all age groups. And then when we looked at income, cases and deaths are higher among lower income populations within countries. For example, in New York City, zip codes in the bottom quartile of average incomes comprise 36% of COVID cases compared to less than 10% in the wealthiest quartile. So here we have this graphic where Manhattan is the skinny part on the upper left. The cases and deaths were less concentrated there as compared to the outskirts of Manhattan and places in Brooklyn. Those places in the outskirts typically are made up of poor communities, and there are also more adult living centers and nursing homes, which we all know were very hard hit in the US and beyond. Next slide. So we also looked at governance, leadership, and social solidarity and found that all three of these things had a large impact. The type and style of governance is a key determining factor in a country's COVID response. So governments that showed accountability, transparency, and consistent communication seem to be responding in a more timely and effective manner. And these are predominantly, it's also important to note that these are predominantly low-cost approaches to transmission control. The World Bank's Worldwide Governance Indicator report states the countries with higher levels of good governance report on cases and deaths earlier and are more effective at reducing fatalities. These findings remained robust after controlling for population size, population density, age of the population, and number of tourists arriving. Some country examples of good governance are in Germany, where 90% of the public supported the government mandates and reported on a high level of communication to control COVID-19. Similarly, in Vietnam, a large public opinion study illustrated that approximately 62% of Vietnamese surveyed think the government is doing right compared to the global average of around 40%. Whereas in the US, there's very low support for the lockdowns and mandates, and this may be one of the factors of why the virus is so out of control here. So this slide speaks to this is the democracy index. So we see that where there's a relationship between democracy and COVID-19 mortality, which is a surprise and may illustrate the difficulty that democratic governments have in instituting somewhat authoritarian measures such as lockdowns, mask wearing, and social distancing, which we all know are difficult for people both in many ways. Next slide. Oh, I just wanted to mention also social solidarity, sorry. There have been many displays of social solidarity that we've seen the world over that may seem to be trivial in the face of such a large pandemic, but in fact, they've had a large impact on country efforts to control the pandemic. So whether it's Italians who took to their balconies to sing patriotic songs together, or in the UK where a call to support the National Health Service resulted in 500,000 volunteers, which was twice the number they expected. Similar thing happened in Wuhan early on when they asked for volunteers and were overwhelmed by the number of people who participated, or just the public applause for health workers that we saw all over the world from places like Brazil, Switzerland, Denmark, and even the US. So this slide speaks to female heads of government. Women have shown decisive leadership. In a 25-country study, female-led countries fared better as measured by fewer deaths per capita and more effective communications. We've seen this in New Zealand, Finland, Iceland, Taiwan, and Germany. However, when looking at it in the aggregate, which is represented in the violin plots to the right, you see that actually there is, with a sample size of 200 countries, the difference between male versus female leaders doesn't seem to make a difference in COVID deaths. Next slide. Okay, face masks. So among that non-pharmaceutical interventions, face masks may be the most impactful on reducing transmission. Next slide. So here we have two different points in time, March 31st and June 30th. So you see on the left, most of the countries in the world are blue, which represents a lack of face coverings. Only in China and some parts of South America, a little bit in the US, they're starting to wear or have mandates for face masks. Whereas we look on the right, which is June 30th, almost the entire world has instituted face mask mandates, other than the Nordic countries and Australia and Greenland. Next slide. So it's difficult to measure who's wearing face masks and the impact that they're having and when people are wearing face masks. So this is a creative way to do that. The red, so we looked at Google search for the term mask. So the red represents where there has been more searches for masks. And the important thing to point out on this slide is the timing. So the first tranche of countries is Southeast Asia. So we start to see red around the end of January and then throughout. Whereas in the next grouping of countries in the middle, the US, you don't start to see red until late March, early April, meaning that people weren't searching for face masks. And then we can make the assumption that people, when they're searching for face masks, trying to buy face masks, learn about face masks, they're actually wearing them. Same thing holds true in Europe. People weren't really searching for face masks online to learn about them and where to buy them until the late March, early April timeframe. So again, this shows a big difference that because historically and from SARS, there is more of a tradition and an acceptance of wearing face masks in Asia versus in the West, where this was a new thing. Next slide. Again, this is looking at the timing. So where 0 is the first 100 cases. So we see in the first grouping of countries that people were searching for face masks before the first 100 cases, which we now see we can assume made a difference in transmission rates. Whereas in the bottom 2/3 of the countries listed, the US and Europe, people waited for the first 100 cases and then thought about mask wearing as an effective mitigation strategy. Next slide. So hand washing. The CDC and WHO really promoted hand washing based on the effectiveness of this to control a seasonal flu. It seems to have had, based on this data, less of an impact with COVID-19. So again, looking at the timing, the 0 represents the reporting of the first 100 lab confirmed cases. There's a little bit more blue to the left of that in Asia as compared to in the US and Europe. People didn't really start reporting washing their hands, or sorry, searching for the information on hand washing and COVID until later on, more around the first 100 cases. And then after that, it doesn't seem that there is an increase in searching for information on hand washing when the pandemic really took off. Next. I think you're muted.
You are muted, Ariel.
Thank you. Thank you very much, Hilary. One of the questions we had in the summer when we launched this exploration is a great concern that given that the East had not suffered the big spikes of death that the West had in the spring, that they will be likely having less levels of community immunity, and that will make them more vulnerable to have a really exponential phase of their epidemic by the end of 2020. That was our concern. There were some, we didn't know exactly what was going to happen, but obviously we now know the answer. Next slide, please. We were concerned because waves are known to occur. You remember there was all this conversation about second waves in the summer. With the Spanish pandemic, as you know, there were several waves, all of them correlated. Well, in that case also information and reporting because of World War I was limited by some, but also mobilization. So it was a different type of world before air travel. But nonetheless, several waves were noted at the time, and as behavior and travel and immunity were evolving. So we were expecting something equivalent for Asia. Next slide. And yet we now know, as we have seen, that by the end of the year, we saw pretty much the same pattern that we have seen with worse mortality in the West than in the East for the whole year, as we heard. Not only we expected like a tenfold, and it ended up being 100-fold mortality, median mortality rates for Western countries compared to Eastern countries. Next slide. And indeed, it's been all over the news, of course, how despite the fact that Europe and the United States may have had some more higher levels of immunity, they had a far greater spike, even greater than the first, whereas Asia, like Africa, that is a very young continent, didn't. Next slide. And yet, as you zoom down to the lower scale, obviously a log or 2 logs down, you can see that things nonetheless are going up in Asia, but still a very low level. Nonetheless, the trend can be worrisome, and we had to keep an eye. The vaccine may preempt, arrive just in time. Back in August, we didn't expect the vaccine to be available before the end of the year, and that could make a big difference. We expected the vaccine might take a year or two, and now these might change things, particularly for Asia. We'll see. As we know, implementation is going to be a challenge. Next slide. So indeed, within in Southeast Asia, for example, countries like Indonesia, Myanmar are above that trend, Philippines. Yet we still have these superstars in the regions like Thailand, Vietnam, and Singapore that have continued to successfully repress the epidemic. And again, it's the Suit has mentioned, or Richard, I guess, is better to be lucky to be good, but they are probably doing some good things there, and despite, besides some of the structural factors that we have now explored. Next slide. And as we noted here, even the early stars, South Korea, Japan, you can see how they are now entering what could soon become an exponential phase. It's too early to tell, but especially now with the Chinese New Year coming, these trends are very, very worrisome. Simone, can we go back? Simone, can we go back?
This one?
The PowerPoint,
okay.
please.
No, because it stopped.
And clearly, and the next section of the slide, next, please. Again, all of these suggest that the early consideration of immunity in the West growing faster because of the largest burden of disease was not enough or necessary. It was not enough in the West to preempt the second wave, and it was not necessary in the East to continue to suppress the epidemic. There's a platform called Zero Tracker, which group of students from Oxford and Canada and others with support of the Canadian government that has been compiling all of their surveys done around the world. And as you can see, not enough surveys to understand this dynamic, and many of them were earlier in the year. They have now published a meta-analysis of all the surveys. And the next slide shows some of their findings, which explains only partially what's going on. Click. Yeah, so there were almost 400 seroprevalence studies, over 2 million people in 50 countries, and most of them before September, so things have certainly gotten worse. Seroprevalence was low in the general population, about 3.4, slightly higher, and in healthcare workers in high-income countries. And so the high-income countries, which is in the West, have a slightly more seropositivity now, and this is slightly now at least twice that, if not more. The median seroprevalence varied also, and it was only 1% in Southeast Asia compared to already nearly 20% in South Asia. This is already by the summer. So South Asia, which we didn't look at in detail, has certainly been seeing much higher burden than Southeast Asia and the East. And so, as you can see, the immunity levels in the West at that point were 5, maybe 10 times greater. And they correspond, of course, to the greater infection. National studies had lower prevalence than local studies, obviously, because they were in the first half of the year. Many rural areas had not yet been hit, particularly in the West. Seroprevalence was higher in younger people compared to the elderly, and that's been shown in young people going out without masks and so on. Healthcare workers had nearly twice the immunity than the general population, and that also corresponds to the increase in COVID among those exposed populations. And the seroprevalence estimates from national surveys were 12 times higher than the cumulative incidence, meaning for every case that we have been reported in the first half of the year, there were probably 10 times as many. So as we know, right now in the world, there have been over 2 million deaths and over 100 million cases. If you multiply that times 10, it's quite possible that the world has already suffered over 1 billion infections worldwide. And again, that's an incredibly large number, never seen before with H1N1, and clearly not by the first SARS. Next slide. Now, our chair, Lincoln, and asked us to also look at biologicals. We really couldn't, the scope of this couldn't allow us, the data couldn't allow us, but it's worth mentioning a couple of observations, right? There have been many biological explanations that have been explored by different articles in different angles, and biological reasons why the Asia may be more immune to the virus, right? Certainly, we do not know enough. We try to look at immunity from flu epidemics and so on, nothing that we can find, not enough data actually. They've been an observation that the Neanderthal DNA residuals in the West provide some susceptibility through HLA variation. And maybe that is the case, and so it's possible that some genetic makeup in the West contributes, but the proportions of these are relatively small compared to the more prevalent Denisovan DNA in the East. Others have looked at the levels of vitamin D, which tend to be higher also in tropical areas of the world, but again, no consistent data that we can find at the national level to run an association here. We also know there's also been an association with protective levels of blood type O, which are more prevalent in the East. And again, all of those are possibilities that it's hard to pin down with available data at this national level. And in any case, we know that the social factors in America, for example, we have seen the highest mortality among African Americans, even though Africa itself had not had much of a mortality rate because they're a younger population, but the social factors are important. Likewise, in the United States, Asian Americans have suffered less than African Americans and Hispanics, but also overall slightly more than white populations in America. So again, underscoring social factors being perhaps more important than the genetic makeup of the populations. And now the genetic makeup and mutations of the COVID-19 virus itself, those are, as you have heard recently, being explored. The virus there's mutations, although there's not as much drifting as with the flu viruses, and those mutations may have contributed, but so far there's been not an observation that particular clades in Asia and particular clades in the West explain the difference. The most recent clade that has been showing to spread slightly faster in the West is too recent to explain what the whole year gave us. Next slide, please. Well, after this tour de force, let me just start by saying again, thanks to Lincoln, to China Medical Board for encouraging this effort to look at this divergent epidemic. And I also want to thank Simone Villa, the session co-organizer, also for doing the bulk of the analysis. So COVID clearly is a regionally bifurcated epidemic, and it's also clearly an age bifurcated epidemic. From the beginning, Asia and then the rest of the world show that the elderly are the ones most likely to die. This is an ecological analysis and is subject to the usual limitations and aware there's diversity within each of the regions. And yet we attempted to explore a range of factors. Suit, that many of you know, has said that it's really too early to draw any conclusions. And the epidemic is fluid, the data is imperfect, and more importantly, that Asia should be careful to claim any success, given things are still moving. So what could be a rock solid success may be really turning into moving sands if immunity does not reach level with immunization with vaccines soon. Yet we have a few observations, and that I think the data backs up. Some that will need to be reviewed and making adjustments in multivariate analysis, which is harder in ecologics. And nonetheless, we should probably look more at age adjustment for some of the other observations and correlations that we presented today. Next click, please. So Asia was successful in stopping the exponential COVID, while the West suffered not only a 10-fold higher mortality rates, but it is, the fact shows, 100 more median mortality rates in the West than in the West. Next. This early success has been sustained in the second half of 2020, while the West experienced a very large second spike in deaths. That's also clear from the data. Next. Growing COVID immunity was not required in Asia, and it was not enough in the West to preempt as a big second wave of mortality. Next. Early overconfidence and poor leadership may have been a weakness in some of the Western countries. Clearly, we were late in testing, we were late in masking, we were late in many things. And of course, you have seen how the United States has suffered the worst of all the epidemics. Clearly, the president last year was absolutely missing in action. Next. General lockdowns and that were popular in the West were not sustainable or effective, as we saw in the end. There were short-term measures. In Asia, they were not used. Most of the countries did not use any generalized lockdowns, although stringency measured by other means were higher and earlier in Asia than in the West, before everybody panicked, of course, after WHO declared this a global pandemic in mid-March. Next slide. We knew this from the beginning, and the analysis backs it up. Age is the most important risk factor for COVID mortality, and it is also at the ecological level. So that vaccinating the elderly is a priority, and that will prevent the most numbers of deaths. I mean, if you just immunize everybody equally and you reach 50%, you will decrease 50% mortality. If you tilt your immunization towards the elderly, you can reduce that to like 80 or 90%. Early mask wearing and early testing that were clearly more so in the East may have contributed to this tentative success in Asia. And so the important to continue those, and we're happy to hear that yesterday with President Biden arrival to the White House, one of the first resolution is mandating mask use in all federal institutions. Now, countries with older, but also more urban, more obese populations suffer more and may have contributed to the difference between the East and West. And I think that those are clear. Obesity in particular have been very, very important. Interestingly, at the ecologic level, and given that the West was hit so hard, we found paradoxically that democracy didn't protect them. The higher WHO preparedness index in the West did not protect them. Greater health insurance coverage did not protect them. A lower Gini coefficients of inequality did not protect the West. And that the East, even with higher median household size, also that wasn't enough to lead them to exponential growth of the epidemic. Again, these are at the ecologic level and the national level, but again, quite counterintuitive. So observations like that is something that deserves further review, but clearly the obese populations, obese countries, urban countries, older countries, and older countries from the beginning. I remember when we were looking at Milan and in Italy, where 25% of the population over 65, they were having a massacre, really. Whereas again, in Africa, with less than 3% of the population over 65, had not seen the explosion of mortality. And cases as a whole, we haven't focused as much because of the great variability of numbers driven by the intensity of testing. Now, as explained just before, biological risk factors were beyond the scope, but it seemed like they pale compared to the social factors once you move, as we looked also at the ethnicity outcomes in the United States. And next click. So I think that while Asia has done clearly well compared to the West, they remain very much vulnerable. And with the Chinese New Year upon us, and things can still turn for the worse. I mean, the rate of vaccination is not as fast as the rate of infection when COVID starts spreading, as we are now witnessing in Japan and Korea. So if that happens, again, natural immunity will be faster than vaccine immunity, but eventually the two of those will hopefully lead us to a slow and eventually end. Although at this point, we will not know whether this virus remains endemic and vaccination becomes an annual ritual as we do for the flu. So with that, thank you. And I would like to pass it back to Lincoln to invite our two commentators and then questions and answers. Thank you very much. Next.
Thank you, Ariel, and thank you, Simone and Hillary. I would love to hear from Dr. Rapapong at some point, particularly about Thailand's resurgence now, because the epidemic seems to have taken off somewhat in Thailand. But let me comment with some questions on the presentation. First of all, this is an ecologic analysis. And so there's no causation, it's correlation. And some of the correlations suggest causation, but some are also paradoxical. For example, Hillary, you're showing the correlation between the density of health workers versus the infection rate and mortality. And of course, that suggests that health workers kill if you have a causation there. But obviously, it's that the richer countries in the West have a higher density of health workers than the East. The data itself needs to be thought about in looking at ecologic analysis, because some of the data are fairly strong, presumably the demographic data, for example, but some are of mixed quality and unknown. That includes, I think, the incidence, maybe less the death, but certainly the incidence or the prevalence of the infection. COVID-19 the coronavirus is an equal opportunity invader. So the question you're posing is, why is it that the opportunity seems to be so much greater in the West than in the East? And your ecologic analysis is so striking, I must say. Thank you very much. I think this study definitely should be published, because you have laid out the baseline questions for looking at this epidemic that all of us are going to have to grapple with over time. I don't think you've answered all the questions, but I think you do provide a lot of the basic study parameters for others to examine what's actually happening. I suppose one could have asked, did you look at specific countries? Because I'm intrigued by in Southeast Asia, the reported success of Vietnam and Thailand in comparison to the Philippines and Indonesia. Are there differences across those countries? In Vietnam, what we're being told is that they stopped the movement of Chinese into Vietnam. They also did testing and contact tracing, and there was a huge amount, according to reports, of political community mobilization to get people not only to wear masks, but also to identify those who are with cases, and then to quarantine and isolate them in comparison to others. I don't know about Thailand, but that is one of the puzzles. I think you've done as good a job as you can on the biologic explanations. I'm not sure we're going to get much further unless somebody comes up with other kinds of immunologic history of populations. But why would all of Asia be so immune to the virus in comparison to all of the West? I find that very, very puzzling. So I'll conclude by saying, I think, you know, what has happened, you lay out very nicely, and you also lay out very nicely related parameters like obesity, age, and so forth, that are risk factors for the virus and its death rate. Why and how it's happened, I think we're still left with a puzzle, but I'm sure we will learn more, and I would urge you to publish your paper. Thank you.
Thank you, Lincoln. I think we have Ripipong online.
So it's my turn, right? Okay, good evening from Thailand for all of you, and thank Lincoln for your moderating. I have 5 minutes, right? So I will be talking very quick. First of all, I think the topic here is about the comparison between the East and the West. And you seem to have a hypothesis that the East is successful in controlling COVID-19. But Ariel, you also mentioned that perhaps it's too soon to claim the success of the East. And I do agree with that, because now Thailand is facing the second wave, or we may call the new wave of pandemic, which is more dramatic than the earlier one. And ironically, it happened after the high-level officers, for example, Tedros from WHO already praised Thailand about our success, and a few days after the press, we faced the pandemic. So perhaps this is one. So this is quite a bad job, but anyway, perhaps it's one of many things that we may explore later. From your presentation, I found that it's very interesting that you, Simone and Hilary, try to lay out the contributing factors why the East, I have to say, is seemingly successful in COVID-19 containment. However, there are some, I think this is a good point to start, and there should be many more works to do on, and I agree with Lincoln that perhaps we need to look into detail in specific countries, and because of when we mention that ecological study, you may know that ecological study may always face ecological fallacy. So sometimes we may miss some causative factors based on our methodology, so-called ecological study. For example, Germany has the leader of Germany is woman, right? And also this is the same situation in Taiwan. So perhaps it's not about the East and the West, but it's about the contributing factor behind the East and the West. Japan is one of the countries in the world with the highest number of the elder populations, while Japan is facing a very low mortality rate compared to, let's say, Italy or US. Therefore, I suggest that perhaps I suggest and I also urge myself as a researcher as well and other researchers around the world to look at some qualitative factors behind. For example, I think we haven't mentioned much about the sense of communalism or the past experience. Let's say, for example, this is just a very rough hypothesis from me. For example, the past experience of many countries in the East that they have passed through many severe wars, and that perhaps the sense of communalism is not about the authoritarian of communalism, but the sense of communalism that people gather together and try to fight together to pass through the pandemics. Perhaps this is embedded in the habit of Asian culture or Asian people, and this could exceed or could conquer the overly individualistic manner. So perhaps this is one of many factors that many Asian people are very complying with face masks, hand hygiene, or any measures that are launched from the government, even though they are, regardless of their feeling towards the government, they still comply or conform to the government measures, even though they are unhappy with the government. One minor thing that I would like to mention, perhaps this is my last comment, is that I think we overlook the function of the health system in the East. I myself, as an epidemiologist, and I have to go into the field investigation for COVID-19 as well. Sometimes we have to communicate with other researchers or other the epidemiologists from other countries. I found that many countries I'm not sure whether it is many, but Thailand, of course, and several countries surrounding Thailand, we heavily focus on the case investigation and contact tracing rather than the treatment itself. Since the very early phase of pandemic, therefore, I'm not surprised by many health index or health system index generated from the Western world shows paradoxical phenomenon that many countries that have very high, the very advanced treatment technology finds difficult situation in fighting COVID-19 because many index always focus on the treatment side without while ignoring the function of the disease control and investigation. So this is just from just a minor observation from me. So happy to learn from you all. Thank you, and over to you, Lincoln.
Did you want to make a few comments?
I think we have Richard. Richard Cash.
Yes, thank you very much, and my congratulations to the group on a rather huge task that they've taken on and very effectively. Let me make a few observations and comments. First of all, it's clear that the strategies that were used early on had some impact on reducing the early spread. And the strategies used early are not the same strategies that are used later on. For example, in the United States today, I don't think contact tracing really has much value given the extent of the epidemic. The second observation is that I think far too much emphasis has been put on this concept of herd immunity. And those of you who know me know that I do not like that notion. I consider it community protection, because if others around you are immune, you're not immune, you're protected. You're not immune, you gain no a biologic immunity, you only have protection. And I think it's been tremendously overemphasized and to reach the so-called 60%, and that number is somewhat taken out of the air, we will see the end of this pandemic well before that period of time, just as occurred in the 1918 influenza epidemic, when no one knows, by the way, at what level of immunity there was reached in the world before that pathogen disappeared. And the last point that I want to make is that like all infectious diseases, this is a social disease. It's the same pathogen, whether you're in Boston, where I am, or whether you're in Bangkok. The pathogen does not change. The risk factors change. We know that obesity, well pointed out, is a major risk factor, as is age. Now, let me challenge one of the notions here that smaller size families or smaller size number of people in a dwelling is inversely correlated. That is, higher numbers in a dwelling decreases risk. I think that what we have to look at is how are people housed and how are they living. In Boston or in Massachusetts, 65% of all deaths, 65% are in chronic care facilities, and the average age is 82. Now, I consider a chronic care facility as being a single living unit with lots and lots and lots of people crowded together in in situations which enhance the spread of this pathogen. And so I think we have to look at how people are living. In much of the East that you have mentioned, chronic care facilities are not very common. Most elderly live with their families. There is not the same social structure that we have here. Throughout Europe and the United States, chronic care facilities have become the warehouses of the elderly, as have old age homes. And these are not nearly as prevalent, even in a country like Japan, which has the world's oldest population, as well noted. And South Korea and Taiwan also fit in that category. So how people live, how people interact with each other. Are they a community where they shake hands or where they touch and so on? Or are they societies where social distancing has a role to play? How are the elderly looked after? How do they live? And this, I think, is very, very important, because when you talk about immunization strategies for Thailand or the Eastern countries, I don't think that given what we know of this pathogen, does it really make sense to immunize everybody in the country, or only those people who are at particularly high risk? And I would say the same thing is true in the United States. We should be focusing on those who are at high risk of getting infected, but mostly at high risk of death. And therefore, how people live and their social interactions are absolutely critical to this disease, as it is with tuberculosis or any infectious disease. Thank you very much.
Thank you very much, Richard. And Lincoln, if I may then, and then Simone and Hilary, we can just respond. And we see a few questions already being typed into the question and answer section. And so let me start by saying first, thank you again, Lincoln. And yes, ecological analysis, like all analysis, like all data, can only provide partial answers to questions. More often, rather than giving you the truth, they challenge your own assumptions, all of these models. But there are several important questions here. One is Maria Kuzina asked whether the West may look worse because of better reporting of deaths and cases. And while case detection could be an explanation for the differential with, say, Africa case detection, the fact is that Asia seems to be detecting better cases because they're doing a lot more testing per case detected. And so it's quite likely that in a way they are more correct in their cases than the West. But again, there's a 10 to 12 differential between cases and immunity. So there's plenty of room for variation there, but the consistency is quite clear. That is why also we focus on mortality, because deaths are easier in a way to account than cases. And even though there's still some wiggle room there for variation, that I think is very, very unlikely to explain. I think like when you look, the age structure probably is a lot more important, but it's a valid question because these numbers are all imperfect. Now, a question that I saw earlier also from Peter Kilmarks is that about the importance of contact tracing. And so we heard from Ripi Pong how that may have been a very important factor in Southeast Asia. And whereas Richard Cash suggests that in America, it plays a very little role. And I think the difference here is timing. Because as pointed out by Richard, this is a very, 40% of the cases are asymptomatic and pretty much 90% of the cases are unreported. So there is indeed a vast number of cases that you miss in the community. So traditional public health interventions only work early on, as we saw in South Korea and again in Southeast Asia. So if you are early or and as long as the cases are few, you can do this very well and encircle. SARS, we succeeded with SARS because it was a lot more clinically apparent. That is, there were not an iceberg of asymptomatic cases in SARS-1. And so the contact tracing and also the very early response was probably key. And so once the cat is out of the hat, as Dr. Seuss will put it, it's very hard to use the traditional contact tracing. And in New York, because everything came late, testing and everything, by the time we were in the spike of death in April, the governor, who did a great job otherwise, in this case also called off this intense contact tracing. Once the numbers go back down, contact tracing again is my view that will be very important. Of course, those efforts must remain. And I believe that delay in response, delay in contact in testing, delay in contact tracing, delay in masking, and higher travel in the West, all of that allow for a very early spread, probably all the way in December already, of the virus in the West with no response whatsoever. Once it spreads, it doesn't matter whether you are rich, whether you have good health systems, whether you have great democracies or not. The virus is already out of in exponential phase, and it's very hard. So everything else becomes confounded by the issue of the timing, and including the size of the households, which Richard correctly points out. The median household size, which is higher in Asia, doesn't take into account the fact that we had a lot of nursing homes, elderly in nursing homes, which are not covered in this household size statistics. And unfortunately, we do not have good statistics on nursing homes residencies around the world to use that as an adjustment factor. So clearly, that overrode the early start in the West. The nursing home spreads, which accounted for half of all deaths in the United States in the first phase of the epidemic, and even higher in some states and other Western countries. Clearly, that takes away any conclusion that a higher household size is not a risk factor at the individual level. Richard also speaks of community protection, and that is indeed the case. It's very low, regardless of what you call it. The prevalence of the zero prevalence is still very low, and so it clearly was not enough in the West, where I mean, in New York, we were at 23% in April. Maybe we are 30 or 40% now. The same thing might be closer to that in Sweden. But the fact is far from this magical 60, which is not too magical, but the 2/3 levels of immunity required to protect members of the community. But as Richard will remind us, even people who are in such a nirvana, once they step out of that community, they still are not immune and can still get hit. And so we still have a long way to go before we have enough vaccine or enough natural immunity to bring down this. I may also just mention that others are thinking that climate also may play a role. And I think that's an important variable, time-dependent, of course, variables that we should explore. I thank you for that. And maybe Simone and then Hilary can also address some of the questions. Simone, you are on mute. Okay.
Yes. So I was trying to, because they written some question in the Q&A and some of them in the chat. So the first one, Biroj, if I pronounce it correctly, was asking if about hand wash and face mask, that the perhaps using research volume from Google Trends wasn't a good indicator, but I think Hilary and Lincoln replied that, and myself, I agree with him or she, because about that, but we have to rely on this type of indicator because it is available for most of the countries. We have studying, so we decided to go and pick this type of variable. And I also have, so you have also commented on some of the question about Peter, that also suggested us some articles strengthening how because the goodness to use the ecological study, because it's much appropriate for infection diseases.
Simone,
yes.
If I could also jump on the masks issue question by Vero, that to us, yes, this is an imperfect, indirect way to assess. The baseline is also higher use in East over the West. We know that, but also, and of course, access to Google is greater in the West, so that will make even more. We were particularly interested in the timing of these searches. And it was clear that the timing in January in Asia compared to the timing until April in the West suggests that delay in mass search probably corresponding to delays in mass usage. And it's this delay that I think is a more valuable observation than the actual level of intensity of the searches.
Ariel, could I make a comment?
Please.
Going back to this last comment that you made, I think that maybe it would be useful to look at messaging. That is the consistency and the timing of the messaging. In the United States, we had all sorts of different messages. Don't wear a mask, wear a mask. wear a mask here, don't wear a mask there. I suspect, but I have no way of knowing, and this is something you could do, is that the messaging within most of the Asian countries was clear and much more specific, and was not sort of waffling between this and that and this and that. That is, this is what we recommend, period. We've gone back and forth in this country from whether you can have 10 people gathering together or 50 or indoors or outdoors. The messaging has been very, very, very inconsistent. And because we have 50 states, it's been divided into 50 different parcels. So
Right.
consistency might be something worth looking at.
Agree, Richard. And in fact, one of the anonymous attendees here asked a question as to how come that after you implement such interventions, they are not, that suggest having effective. However, in the West, it hasn't really controlled this. And I would say to what Richard has pointed out is the answer to that question. That is, we have not only been consistent at the same time, we have been inconsistent over time. That is that clearly we went in all the way to lockdowns in April in the West, but then we relaxed. The stringency index clearly was relaxed by the summer. And for all sort of reasons, people got tired, people thought it was going to go away, people thought immunity was growing, whatever. And we lowered the guard again, and that lowering of the guard allowed the virus to reach exponential levels again. Once it reaches exponential growth, again, it's very hard to contain it no matter what you do until you do severe measures, which is what has happened in the West. So yes, the inconsistency of messaging at any time and over time matter. Hilary, any comments from you?
Yes. So I'm happy to see that people seem to be very interested in the social aspects of this pandemic. As Lincoln said, we have laid out the social parameters of what's impacting, of what we see impacting transmission and mortality. But that was our task, was just to lay out the parameters. So you've all raised some really interesting questions around the importance of what is it about government, or is it the social solidarity in certain types of government that's actually playing a role? To what extent has communication played a role in the consistency and timing of communication? These are all really fascinating questions. We think they're really fascinating questions, and that's would be the next level of analysis, and then maybe even to look at country examples. But we are 3 people taking this on. So I've said before, looking at what the parameters are more in depth and what the confounders are would be several PhD theses. So thank you for supporting the importance of that this is actually a social virus and how important these aspects are. And we recognize the limitations of what we're presenting as well. But again, the task was just to present what these parameters are.
Thank you, Hilary. We don't see any other questions. Perhaps if any of the panelists would like to go through a round of comments and final reactions before our chair addresses us and closes the session.
On the messaging, Ariel, this is Richard. I think we should also, I don't want to cast aspersions, but we ought to look at the messaging that also came from WHO. WHO did not validate face covering, which is a term I think we should have used rather than masking, because even if masks were not available, face coverings always were available. They did not validate this until I think it was May, if I'm not mistaken. It took a very, very long time. I think an unconscionably long time to actually make this a recommendation, something I've never really quite understood.
Thank you, Richard. Indeed, as you could see from the data we presented on Google searches for hand washing, WHO had a flash of communications around hand washing. Even the DG sort of You could see the videos washing hands. Everybody invited stars to wash hands. There was a lot of that happened in a flash in February. And that flash led to everybody looking at hand washing more or less at the same time, really. And then they forgot about it. And it was the differential in masking that seems more important. And you are right. By now it's clearer. I think it should have been clearer and obvious from the beginning. And WHO could have stepped up earlier on the mask usage, which is now finally so. But it might be too late for those countries that went through the early wave. Thanks.
On a methodology issue, Ariel, could I ask Hillary and Simone, what did you, when you looked at lockdown, what do you consider recommendations not to have large indoor gatherings? Or in other words, it's not a lockdown so much as a set of recommendations to reduce getting together in enclosed spaces. Commerce still goes forward and so on, but indoor events don't, or bars are closed or something like that. Is that a lockdown, or is that just a simple form of public health messaging?
So for the stringency index, I think you are referring to that one.
Yes.
We use the stringency index was developed by the Oxford University, so is a composite measure. So it includes mass gathering outdoors, but also indoors, and lockdown measures, mask covering, testing. So it's a composite measure. So it gathered together like 20 indicators.
I see.
So
Thank you.
welcome.
Well, let me, if it's okay, Ariel, let me just take this opportunity to thank you, but also Simone, Hillary, and Rapipong for a wonderful study. I urge that you publish these data, because while there are huge differentials of great interest, there's actually very little out there that has looked at systematically what you've done. And I think everyone will find it useful. It will support and refute some hypotheses that are out there. So I think it's great to have this analysis. It struck me that another kind of approach would be to look at crisis management, because this is not just a straightforward event, which has the correlations of the ecologic fallacy, but there is the question of fear, uncertainty, lack of assurance about some of the elements of control. And as Richard was talking about, how do you communicate that? And how does it change as the crisis proceeds? I think Hillary's data on the correlation between the deaths and democracy are very revealing, because the more democratic societies seem to have higher death rates. And I guess I was thinking, in the United States here, we've had a transition of the president in the last 24 hours, and I would use the word demo-crazy. Demo-crazy rather than democracy, because that's the other, there's a thin line between democracy and demo-crazy, which is people going crazy. And that obviously gets into the politics into the US, but that's probably not an issue that we should leave off the table. So in any case, those are some of the considerations of what I consider an excellent job well done, Ariel and team members. Thank you very much.
Thank you all. Thanks to our Secretariat for their support. Don't forget to click in some of your feedback and evaluations, and the session will be recorded in video and shared through the PMAC website for those who will be interested. Hopefully they will share the link with all participants so that they can share it. Thank you. Oh, Virosh raised his hand. It's something new. Let me see, how do you raise your hand here? Virot, are you there? Would you like to make a comment before we go?
Just only thank you to you all. Much appreciate.
Okay. Well, thank you very much. Thank you all.
Thank you, Roj.
Thank you.
Thank you all.
Thank you all.
Bye.
Thank you.